Hi, today I would like to discuss a case with you. This is, we can see there's an unconscious lady. She's 70 years old. She found unconscious at home after her neighbor checked on her, then called the ambulance. She's found hypotensive and tachycardia with the blood pressure 80/46 with hypoxic, and she's sent to resuscitation bay. And first, you have to, everything have to happen very fast, but you can't miss any important steps. So the following tests or examination, they technically they should happen at the same time in the clinic. But I will talk about them slide by slide. So first, you have to check the crucial parts: the airway, the breathing, circulations, cardiological examinations, and pulmonary examinations. So I have the observation result for you here. First we have to make sure there's no obstruction of the airway, obstructor, and then you have to check the breathing. So this lady, we can find her breathing diminished bilaterally, symmetric breath sound, they diminish bilaterally. Then sonorous respirations. Then on the circulation examination, there's a weak, this means weak, fairly weak, peripheral pulse and poor capillary refill. At this point, combine these two, you can already judge, have a judgment on this lady is in a critical stage. And then then you continue check on her cardiological and pulmonary examination. You can find the tachycardic rate and rhythm, no murmurs, rubs, gallops, and then this clear for auscultations, no request, no wheeze, no ranking, no revs. So then still is not enough for us to clear what happened on her. So you have to order this test immediately, the basic metabolic panel, and then you have to also include the renal function test, and then also include the calcium magnesium level. So the results come out, we have here these anomalies. So we have severe hyperkalemia. So this one is really critical. And once you've seen it, and then you have to make sure you also order an ECG to confirm your diagnosis, and then you have to work on to treat hyperkalemia at once. And then find there's other analysis. So there's a high chloride, and then here's low bicarbonate, so it means she's having acidosis. And then the BUN, the blood urea, the level is 21.1 molar. So combined with increased high level of creatine, so we can think that there might be a renal failure, although most of the time it means renal failure, but still you can't exclude other possibilities, such as some other case they might represent dehydration, but it's not, obviously it's not in this case, so I didn't include it in this slide. But always remember, you cannot exclude other possibilities in this such early stage. And then we order a FBC full blood count, and there's no abnormalities, and then the ABG, and then it also help confirm the diagnosis of acidosis, this low pH here, and then whenever there's a fainting unconscious patient, you always make sure you order finger thick blood glucose to exclude or confirm what if there's a hypoglycemia. And then in this case, her blood glucose is normal. And then you also have to order, if it's possible, still it might be extra, but still it is recommend. So order chest x-ray to see if there's any pulmonary embolism, such that like other important and fatal condition. So in this patient, we can almost exclude pulmonary embolism. And then also since this patient is unconscious, you have to make sure she's not drinking too much. So you order the level, and then you can never ever like exclude the possibility of she's having a heart attack, heart failure, CAD, coronary artery disease. So you also need to order a troponin and to see if she's having such problem. So luckily, maybe at least she's not having heart disease according to this result. And then here we have our ECG. You can see obviously there's is something bad going on. So let's try to read, try to describe what happened here. So obviously we cannot identify the P wave. So this is an absent P wave, and this form, this shape, we can identify this shape. Let me show you. This shape is like a wave, right? So, and then you can also find the QRS complex is widened, obviously widened, and then you can identify this as the same pattern, wave pattern. This kind of pattern is explained by a regular rhythm, although it's a normal, but still it's a regular shape, regularly abnormal. Then with no detectable P wave, we cannot see any P wave, and then also you cannot like clearly identify the T wave. So there's a fusion of the QRS complex and T wave. So such things combined together, they create a send wave pattern. So this is obviously a severe hyperkalemia combined with the test result we got from the previous slide here. 8.5, this is a range of severe hyperkalemia. Moderate is 6.5 to 8, and the mild is 5.5 to 6.4. So this one is 8.5. So this is a severe hyperkalemia, and combined with this ECG, we can judge this patient is in a very, very, very critical stage. You have to treat her at once immediately. So this happened. All this stuff happened at the same time. So once you got the patient, it's sent to your post. Like you have to arrange for the IV insertions, the 2 IV insertions, and then you have to connect her to the monitor to monitor her heart rate, her oxygen saturation, blood pressure, etc. Everything on the monitor, and then give her oxygen. Like first you have to give her the big valve mask, but this one might not be. This one just a template procedure. So soon, once you identify she's in such a critical situation, you arrange to to have an endotracheal intubations. Also, you can place or gastric tube. So this tube, if the patient have a nasal come with a nasal gastric tube, you can already order a suction to remove the acid and potassium. Try to remove them by free suction. If no, you can always arrange the placement of this or gastric tube to also for this free suction, try to relieve the acidosis. So when you have relieved the acidosis, you can also relieve the hyperkalemia. About this physiological mechanism, I will explain it in the future slides. And then as soon as you identify the patient is experiencing critical hyperkalemia, you should order calcium gluconate, excuse me, or calcium chloride over 10 minutes. Since this one is short-lived, So you can replace the dose every 15 minutes, and then you cannot. You also have to order a 10 unit of insulin, and this insulin have to come provide to the patient with 50% glucose, which is called D50 bolus. And then you can also order a nebulized salbutamol, a short-acting beta agonist. So some people might already know the mechanism and the reason behind why we order this for a patient with hyperkalemia, but some may not. So I will also explain this one in the later slides. And then we also have to correct the doses. So you order the IV 15 milliliters sodium bicarbonate for 8.4% over an hour. And actually, it's not on this slide, but this patient, she's having hypertension, right? I remember the blood pressure is 80/46. Yes, she's having hypertension. So you also have to give her normal saline to maintain her blood pressure, and then you can also give noradrenaline infusion to maintain her blood pressure in this case. Since we're doing an intubation, so you can give her rocuronium bolus. This is for the sedation purpose for the intubation. So this is if you still cannot correct the hyperkalemia after you've tried everything, every medications and treatment, you have to consider you give her emergency hemodialysis. And at this point, although you know from this lab result, you know she's having hyperkalemia and highly because of this one causing her unconscious, but still, this is happening at the same time. I mean, the different differential diagnosis is all happening at the same time. So although I put it at the later slide, but still you have to think about all this thing once the patient is in front of you. So the patient, according to these keywords, hypertension, tachycardia, hypoxemia, unconscious, and also an elderly, you have to consider every possibility of what causing such thing on her. So you have to exclude you have to think of if there's pulmonary embolism, if there's myocardial infarction, if there's a cardiomyopathy, and since she's having a really, really low blood pressure, you have to think if she's overdose of something. So it's an elderly, right? So heart disease is relatively common, and I can confidently say it's very common in elderly, right? So they might be taking beta blocker. So you have to think about what if she overdose her pills, beta blocker, and then maybe she also have to take digestion, or maybe she's having some emotional problem, so she's taking tricyclic antidepressant pills, and she might be also need to take calcium blockers, or maybe she's having alcohol problems, or she's taking some illegal things such as opioids. So you always have to think about such things when you're facing a hypertensive patient. So, but anyway, we confirm this patient she's suffering from hyperkalemia. So this is a brief table about what are the possible causes of the hyperkalemia. I'm not going to talk through it because there's many books, website, YouTube talk about the causes of hyperkalemia. But in this patient, I want you to focus on thinking she might have CKD. She might taking excessive ACE inhibitor, excess antibiotics, potassium sparing diuretics, or address the beta blocker. I've talked about it, and or other stuff are important, but I'm not going to talk about in this case. So that's another thing I haven't told you, but after you examine on this patient, you find her arm, her right arm, forearm is looking like this. This is a relatively common like office appearance. I mean, but you once you see this, you can identify she's properly having a regular hemodiagnosis, because this is a fistula. So it means she's on this position. So you can already think about she's having a chronic kidney disease. So you have to consult the renal department and then send her to the ICU and arrange for the emergency hemodialysis. She probably missed her regular hemodialysis, because you have to think about this possibility when you encounter an elderly which is living by herself, and then there's sometimes they might just simply forget, or they have some accident, like they are not able to come to the clinic to perform hemodialysis. So you always have to consider the possibility of she's having a chronic kidney failure. So in this case, the patient, she does have a chronic kidney failure. So you you manage her hyperkalemia and send her to the ICU. So here's the interesting part. I always love the physiology stuff. So why we order the insulin, the salbutamol, or you call it albuterol, they're the same thing. And then you have to correct her acidosis to manage her hyperkalemia. So the insulin, this is how it works. The insulin combines obviously to the insulin receptor, and then it kind of like activates the ATP, let the ATPs arrange for the exchange of sodium and potassium. So the potassium will go into the cell from the bloodstream. Oh, it's dead, but anyway, from the bloodstream, and then exchange for the sodium to get out from the cell, and then this potassium goes into the cell, so you can reduce the amount of potassium in your blood. Since we call it hyperkalemia, right? Anemia, it means in the blood. So once you eliminate the amount of potassium in the blood, obviously is treat the hyperkalemia. And the next one is why we give albuterol or salbuterol, or some people they suggest you also can give androgen. In this case, they all combine to the beta-2 receptor. In this case, androgen, it is more it's stronger. It combines to a beta-2 blocker much stronger than noradrenaline. So we talk about androgen in this case. So it's similar in insulin case. So once they bind to the beta-2 receptor, they help the potassium sodium exchange, help the potassium get into the cell and sodium get out from the cell. So you can reduce the amount of potassium in the blood. And then the final one, how can we correct the acidosis and help the hyperkalemia? Because as long as you're having acidosis, your body the extra hydrogen, acidosis means extra hydrogen ions, right? So the hydrogen, your body will try to compensate for such imbalance. So that's extra hydrogen. So your body try to get the hydrogen in to the cell to try to rearrange to back to the balance. So they'll exchange the hydrogen ion into the cell, and then the cell in exchange will give the potassium ion out from the cell. So this acidosis will make hyperkalemia worse because the body is keep trying to balance the acidosis state. So it keep exchanging potassium out from the cell into the blood. So once you correct the acidosis, this will not happen. So it can relieve your hyperkalemia. And then I also have an interesting ECG that I want to discuss with you. Here, since my last video, I talked about Brugada syndrome. If you watch that video, Brugada syndrome, one of how we diagnose it is combined with the clinical criteria, and then with the diagnosis from the type 1 Brugada phenomenon on the ECG, and then this, which is you find ST elevation of V1, V2, or V3 with inversion of T wave. In here, we can find this ST elevation with the inversion of T wave in V1 and V2. But because Brugada syndrome is not simply diagnosed from the ECG, you have to combine with the clinical criteria, and also it's kind of like a diagnosis of exclusion. You exclude other probabilities. So in this case, you cannot ignore hyperkalemia and say, oh, this is a Brugada syndrome. No, this is not. So this is a Brugada phenocopies. But if you ask me, hey, how can I distinguish from them? I try, but there's some research that's saying that I would like to distinguish too, but like actually they are difficult to distinguish between Brugada phenocopy and the actual Brugada syndrome. So I would say you have to exclude other critical stuff, hyperkalemia stuff. Then if the patient is stable and you exclude other possibility, then you can comfortably like you can say it's Brugada syndrome, or else you cannot just read the ECG and then you say it's Brugada syndrome. So it's difficult, but it all depends on the actual situation. So you have to act according to your own judgment. And this is what I want to share, and it's my reference. And thank you for GE Engineering sponsoring me for making this video. And that's all. Thank you so much.